Department of Psychiatry at PGI. His areas of interest include community, non-invasive brain stimulation, general adult psychiatry, and psychodermatology. Major achievements include more than 100 national and international publications, and he is a recipient of PDAI Bhagwat Award of IPS 2006, Murugappa Award of IPS 2022. We welcome you, sir. Next chairperson is Dr. Krishnan Kumar. He's an associate professor in the Department of Psychiatry, PGI MER Chandigarh. Areas of interest include clinical psychology, neuropsychology, and major achievements include more than 55 papers published in reputable databases and edited 2 books in collaboration with international publishers and contributed over 10 book chapters. I would request we have our third chairperson in the house. He's Dr. Lalit Kumar Singh. He's assistant professor in Department of Psychiatry at PGI MER. Areas of interest include cognitive behavioral therapy and dream interpretation and analysis. Major achievements include more than 23 research publications, 16 chapters, and Best Paper Award titled as Perceived Expressed Emotions along epileptic children and adults with or without behavioral problems at Indian Association of Clinical Psychologists 2009. Welcome you, sir. I would request our esteemed chairpersons to kindly introduce our speakers, that is Dr. Siddharth Sarkar and Dr. Aniruddha Basu.
Yeah, good morning to all of you. I think the first session is always the most difficult, but then we have 2 very able speakers to set the ball rolling, and I can't think of anyone better than, first of all, the first speaker, that is Dr. Siddharth Sarkar, who's an additional professor in the National Drug Dependence and Treatment Center, AIIMS, New Delhi. Any one of you who has been to any conference would have seen him because he's a very regular person. He's a very nice speaker and a very dear friend also, and I'm sure he'll do justice to the topic, which is substance abuse in the elderly. As we grow older, we need to know what to do and what not to do. I'm sure we'll get some pointers from that. So that's about Dr. Siddharth Sarkar. The other speaker is Dr. Aniruddha Basu, and Dr. Soni will introduce him.
Dr. Aniruddha Basu is additional professor in psychiatry at AIIMS Kalyani, West Bengal. His basic area of interest is addiction psychiatry only, and he has basically developed facilities of addiction psychiatry at AIIMS Rishikesh and AIIMS Kalyani. He is a recipient of so many awards like BB Sethi Awards, Anil Malhotra Brilliant Award at IASP. So we'll welcome both the presenter, Dr. Siddharth Sarkar and Dr. Aniruddha Basu.
And I would also like to introduce my third co-chairperson, Dr. Lalit Kumar. And so I think first Dr. Siddharth will be speaking about the epidemiology, and after that Dr. Aniruddha will be talking about assessment. So after that we can have some questions.
Thank you, sir. It's a privilege to come and talk here. I have been a senior resident here once upon a time, 2011 to 2013. And there are many fond memories, and that time Dr. Shubham Singh was there as a faculty, and it was a pleasure to work with them. Dr. Subodh also was there, and it has been, and many of the people I worked with have now become faculty here. So it's a kind of a homecoming. And today I'd like to talk about epidemiology and risk factors of substance use in the elderly. I hope not to inundate you with numbers because there can be too many numbers when we talk about epidemiology. We'll see whether we can make sense of those numbers. So this is the center I work in. This is the National Drug Dependence Treatment Center. It's little far away from Delhi per se, but if you make an visit there, we'll be happy to welcome you there. So let me start with not a number but a case. He's a 98-year-old sick gentleman who came to our setting. It's a very high number for an age, but nonetheless this was the oldest person I've seen in our setting, and he was using opium and poppy husk for 6 decades of his life. So it's a very long time that he has been taking. He has been mobile, so for his age he has been able to travel to our center. And he also sat in his electrical shop till 5 years back. Now, due to hearing impairment, he was largely at home because he could not tend to the clientele. And he came due to escalating cost for his opium and poppy husk. So his concern was that it was a challenge to get money from his family members. He could get, but he wanted options out. So he was shifted to tramadol, and he was able to manage for 6 months period or so, and then he stopped coming. I thought that either he has passed away or he's immobile to come. But nonetheless, this was a case. That means that there are at least some elderly who use or misuse drugs, and they probably need some help. So with that context, when we talk about elderly and substance use disorder, the questions that come to our mind is whether they actually use drugs or substances, or they just stop using that. What kind of substances do they use, and what are the vulnerabilities of substance use in the elderly who are at risk? So when we think about substance use in the elderly, we are thinking about whether they are using conventional drugs in that sense, heroin, alcohol per se as well, other drugs like MDMA which is coming up, or are they taking some pills, painkillers, or benzodiazepines, and they are just getting used to these medications which have now become uncontrolled use for them. Whether they are using it for pleasure, that is hedonism, or whether they are using it for alleviating distress. They have pain and they have started to use it, they find benefits, and then the use escalates. So whether we are looking at such a situation, then whether we are able to acknowledge and assess their use in the clinical setting. We are often not attuned to ask about substance use in the elderly. We regard elderly with a kind of respect. So it's difficult for us to ask about whether they are misusing substances. Then what are the targets of treatment in such a situation? Whether we want them to kind of do what they want, or take it because we don't know how long they are going to live, or what kind of problems they are otherwise handling, or whether we want the same targets, that we want them to reduce, stop the use of substance, or we just do something actively, or just wait and watch. So there are certain changes in the body and life circumstances also in the elderly. There is changes in the water and fat content, and hence the same amount of alcohol may work differently in them. There is change in pharmacokinetics. There are additional medical issues that have come up which may lead to the same amount of drugs or substances causing more problems. Then there is issues about strength and frailty, and that also determines whether the person is able to go, consume and enjoy to the same degree, and able to handle the substances to the same degree. Then there are issues about vocation and finances, and then there is retirement from employment, and steady stream of finances may be an issue which may also make people to think about cessation of substance use and difficulty in procuring. Then there is social context as well, and then there is change in power dynamics in the family that occurs with old age. There may be responsibilities or issues about family name which make them to think to not take substances or take it in a concealed manner. And there may be changes in housing, in India to a certain degree, but in the West, many people are moving out from their own homes to old care facilities. So these are the context in which we are seeing the substance use. And now from that, let us see what is the prevalence of substance use. And then National Mental Health Survey data suggests, I hope the figures are visible. In the last row, what we see is the prevalence of different use disorders. Any substance use disorder around 27%, not too less as compared to other ages. Similarly, alcohol use disorder around 4%, again little bit less than the preceding age groups, but not too less either. And other substance use disorder, again minuscule, but nonetheless still present. So tobacco use disorders, again fairly high in the elderly age group. So this is Indian data which suggests that substance use disorder, and disorder here, not only use but disorder here, is not negligible, especially for tobacco and alcohol use disorders. Coming to the prevalences of use as per the National Family Health Survey data, now here also different age groups are available, and in the highest age groups it is little lesser as compared to the preceding age groups, but nonetheless it is substantial amount both for alcohol as well as for tobacco. So that means that elderly, as per representative survey, are using substances, and many of them are still having substance use disorders. So not too less as compared to the other age groups as well, when we look at the data that is available to us. Now, what are the substances? And herein I bring in the data that is available from the United States. Now, the first set of rows is about what is the prevalence of substances that people are using, and use of alcohol is pretty common in the United States. It's well-known fact, and around 60% of the people are using it. Now, this rate is much higher than we expect from India. But this rate I'm bringing in to bring in a context of, as compared to other substances. So marijuana is also present, but it is around 3% or 2 to 3%. And when we go to other substances like cocaine and then to heroin. So heroin in the elderly age group is very less frequent, 0.05% US data, but nonetheless. Now, when we come to number of days of use, so those people who are using alcohol are probably using it 100 days in a year, about once in 3 days or once in 4 days. Those who are using cocaine also similar number of days in a year, but those who are using heroin are using around 300 days in a year. So that means that though number of people who are using heroin is very less, but those who are using it are using it on a regular basis. Those who are using alcohol are also using it fairly frequently, not every day, but nonetheless many days in a week. Now, what about admissions? Over a period of time, is the number of people with substance use disorders in the elderly, that proportion is increasing or not? And yes, that proportion of people with substance use in addiction treatment, that has increased gradually. The majority of these admissions are for alcohol, so alcohol still predominates, but proportion is increasing for other substance use as well. Again, this is US data, but nonetheless that shows that gradually for many of the substances, the proportion of elderly with substance use disorders is gradually increasing. So this suggests that probably this is an issue that comes up and is getting more acknowledgement. Now, the reasons can be many, but nonetheless this is what is being observed. Now, there is a context of place as well. Where you are getting the data has something to do about what data you get. So when we take about data from Iranian older adults, the prevalence of use is around 11%, but what is interesting is opium comes up more commonly as compared to alcohol. So when we talk about a country like Iran, which is very different from US and different from India, we are getting opium as common substance of use. The main reason being pain relief, and substance use being more common in men. This is replicated across several areas. Contrasting this to Japan, which does not have much opioids, we find alcohol use and dependence to be the major issue, and drug abuse and dependence to be 0.1% as compared to alcohol use disorder to be around 1.6%, total prevalence rates of around 1.7%. So context matters, and the country matters. Probably the period of time where we are looking at also matters. The setting also matters. Are we looking at people who are coming to a hospital like PGI, or we are looking at the community? The kind of substances that we are able to find, that is different. So in the hospital setting, we have people with greater severity of problems. We have alcohol and opioids are as a common problem and a presenting problem. People coming with issues of alcohol and opioid for which they want treatment. Tobacco as a comorbidity is common in the any clinical setting and in the community setting as well. And comorbidity is fairly common when we look at people coming to the in the clinical setting. In the community, the prevalence is equal other age groups, and it is not linked to probably severity, and therein we have a continuum between less severe substance use being much more common and more severe substance use being less common. So let me bring in a study from PGI. Dr. Grover, Dr. Mattu, Dr. Basu have been authors in this. So they looked at cases from 1978 to 2003 of age more than 60 years, and all subjects here were males. They were married. They were still working, a majority of them. Herein, alcohol was slightly more common than opioids, and the onset of use had been in 30s. So that means the people have been taking substances for a very long period of time. The mean duration of follow-up was around 10 months, and many of the people were abstinent at the last follow-up as well. So what it suggests is treatment works in the elderly as well. No, we should not think that we should not lose hope. For elderly being admitted, we had run in analysis of our data of admissions done in 1 year in NDTC Ghaziabad. So about 7.6% of the sample was more than 50 years, and 1.9% of the sample was more than 60 years. So elderly were rare, but they were nonetheless being admitted. Again, here we find that all the aged patients were male, and substance use profile was similar to younger population in our setting. That is, opioid was more common than alcohol. When we look at the emergency setting, again a study from here which had approached 300 patients 60 years and above, of which around 80% participated. At least one psychiatric diagnosis was present in 62% of these cases. Delirium was the most common diagnosis in the emergency setting. This is well known that people come when they have problems and cognitive issues, and delirium is a issue that people many times present with in the emergency setting. But what was interesting was that a substantial proportion had substance dependence. Tobacco dependence was fairly common. Alcohol dependence was also fairly common in this population. So for whatever reason people are coming, concomitant substance use disorder is a challenge in the clinical setting when people come. Now let me bring back to two more different type of cases, and I had a 72-year-old unsatisfied client with alleged history of opioid use, who was taking heroin and buprenorphine over decades, and he was homeless, lived by begging near temples and requesting and demanding take home buprenorphine, and we refuse to give buprenorphine if the person is unwilling to come on a daily dispensing basis. He was also requesting for admission and to taper off, and we know that this is a big challenge, and it does not end well, or sometimes it does not. We are not able to do that. It did not seem like an attainable physiological goal, but yes, it can be a measure from the person that he wanted to get admitted because he was homeless, and that was transition, and such challenges come. So we are looking at people not only with problems of substance use, but other ancillary problems also, which are present, and sometimes we are vexed about what to do next. Another case was and why I bring this case is that not all epidemiology is just simply numbers, and then we have cases like this and we are thinking of where to put them. He is dependent on opioids and benzodiazepine. He stopped injecting morphine. He was prescribed buprenorphine. He was taking typically 3 to 4 milligram of buprenorphine a day. He never escalated, never stopped buprenorphine as well. He managed his practice, clinical practice suitably. He was okay, working fine, and spouse was generally come for medications along with this patient. Sometimes only the spouse would come. There were other medical comorbidities which are also present, including cardiac and cardiac issues. He had an MI in the past, and he had diabetes mellitus as well. Sometimes it was difficult to control for them, but he managed through nonetheless. So what I would like to emphasize here is that when elderly people come, they have a host of other problems as well. So problems can be psychosocial problems can be other medical comorbidities as well. So let me give a few threads of some literature from for opioid use, and especially coming from Western countries, that opioid use among older adults is estimated to be small. It is about less than 1%, in fact a fraction of a percent. But the prevalence of opioid use disorder is gradually increasing, and this is reflection of the opioid epidemic in the United States, and gradually increased from 2013 to 2018 by 3 times. Problematic opioid use has increased again almost double from 2002 to 2014, and herein terminology also matters, because sometimes people are not able to pinpoint that there is opioid use disorder. So they label other terms as well, where the substance or the use of medication is not in the prescribed manner, erratic manner. Exposure to prescription opioid in the elderly is around 15%. So many people are getting opioid. Not everybody is having problematic opioid use. So Then among those who are more than 50 years, 35% has apparently misused this prescription for opioids, misused either for themselves or given it to someone else. In addiction settings, opioids were the primary substance of use in around 20% of the admissions. So again, alcohol predominates, but opioid is an important issue when we come to admissions. Individuals over the age of 60 years had the highest rates of mortality due to accidental and intentional opioid overdoses. So what it suggests is that because of frailty, because of physiology changes, handling overdose for elderly becomes more of a medical challenge, more of a medical issue. And there is higher risk of death due to HIV, liver disease and opioid overdose in the elderly as compared to the younger population. There is a higher prevalence of comorbidity as well, including depression, anxiety disorders, PTSD and other substance use disorders in the elderly. There are higher rates of suicidal ideations as well. So we know that elderly suicides are more successful as compared to younger suicides, and herein if you have suicidal ideation, then an intentional overdose being a reflection of suicidal ideation might be a issue. Now there are many physical comorbidities like arthritis, hepatitis, hypertension and host of other things which we encounter in the elderly, which makes the treatment also challenging. Now, what happens over periods of time course of substance use? So people have looked at what happens to alcohol use and alcohol use consumption over periods of time, and generally they find that frequent drinking become more common in middle to old age, most notably among men, reaching around 50% in men aged 65 years and over in a cohort in the United Kingdom. But frequent drinking declines in the old age as well. So there is some changes that are happening as people age as well. So looking at these two things, one, comorbidity and maturing out. So comorbidity is fairly common. Higher prevalence of major depression, anxiety, antisocial personality disorder and PTSD has been documented through systematic studies in the elderly population. Looking at it more closely, in people in methadone maintenance treatment, many of them, about a third, having major depression, alcohol use disorder being fairly more common. So not only other psychiatric disorders, but substance use disorders are also common. Again, in this cohort or in the set, cocaine use disorder also was common, then cannabis use disorder and sedative use disorder. So other substance use disorders seem to be common, but psychiatric illnesses also are an issue in this population. Another thread of data in 140 methadone maintenance patients, 57% had a last year mental or medical issue, and the common among the psychiatric issues, depression, GAD, PTSD seem to be common, but the other more common problems also include arthritis, and this is what makes life challenging for people. Then hypertension is expected, and hepatitis C was fairly common in this population, especially because them being methadone maintenance patients and largely having history of injecting drug use. But other problems like lung diseases, cirrhosis, diabetes, etc. are also other medical problems that are present. So what it suggests is that elderly have a lot of medical comorbidities, and substance use cannot be looked in isolation. Now, do people mature out of substance use? The notion that most drug users mature out has been extensively discussed and replicated across different settings. So this seemingly happens. The rates of both drug consumption and drug use disorders that seems to decrease. This was not very clearly reflected from the Indian data that I initially presented, but nonetheless many other data suggest that maturing out does happen when we look at different age groups. And drug use disorders at different age groups seemingly are different, and when you look at ages more than 50 years, the prevalence rates are lower. The prevalence rates includes both people who have been persisting with their substance use, people who have recurrence of substance use after a period of remission, and people who have new onset of substance use. What I want to emphasize here is that though the proportions are lower, but nonetheless there are also new people with new onset substance use happening in the old age as well. So maturing out does happen. Substance users become non-substance user over a period of time. Sometimes it becomes hence an expectation in the clinical setting that we are expecting that this will happen, and probably that is a reflection of our thought of ageism, that this is what is going to happen with age. It may not happen so. So sometimes it does occur, but sometimes it does not occur, and patients may be concealing substance use, and they become good at doing that over a period of time, and maybe they may become demanding on substance on their family members as well. And I have had patients who had been creating havoc in the family, demanding alcohol to be given, and the family members would have to mix alcohol with something else, with water primarily, and give that. So the person is placated. So that happens. Now, risk factors. The risk factors are quite varied. So we have biological risk factors, we have social risk factors, and we have psychological risk factors, and we have interplay of geographies where these risk factors are in the context and the context of the substance use as well. So having a variety of risk factors which have been evaluated, and some are yet to be evaluated. So when I talk about risk factors, I do not suggest that they are the finality, because some of them might not be replicated from one place to another, and some of them might be just one-off because they have been thought about and studied. But nonetheless, let's see what are the different risk factors that have been suggested. And risk factors for smoking, gender seems to be one, that among men it seems to be commoner. The prevalence decreases with increasing age. The prevalence is higher with illiteracy and lower socioeconomic status, and the prevalence is higher when people are using other substances as well. So these are some of the risk factors for smoking. Then for alcohol use, apparently someone has reviewed and has commented that there is a lot of literature on substance use prevalence, but less literature on prevalence on different risk factors, and that stress, changes in identity and role, friends' approval of drinking, these are associated with increase of late onset alcohol use disorders or heavy drinking in the elderly. Retirement, death of spouse, or a death of a close relative has not been found as a risk factor for drinking. So not this not also has an important connotation, that when we just assume that this might be one of the factors, may not work so. For opioid use among the elderly, higher education, illicit drug use, depression, and pain causing interference with normal work, these are being reported as risk factors as in one of the studies. But when different risk factors are collated and they are so we have a net or a different kind of risk factors. For example, chronic pain, physical disability, poor health status among the biological ones, among psychological ones, bereavement, functional decline, and social isolation, retirement, low income, lack of employment. So many of these has been found as risk factors in the elderly as well. For benzodiazepines, female gender, going to multiple prescribers, polypharmacy, chronic pain, physical disabilities, cognitive impairment, social withdrawal, presence of suicidal ideation, being hospitalized. So many of these have been found as risk factors for benzodiazepine misuse in the elderly. So how do these risk factors help us? These just help us to find pointers that whether this person who's using benzodiazepine, using it as in greater amounts, whether the person needs assessment for having a disordered use or not. Now, a brief about assessment of substance use disorder in the elderly. Dr. Anirudh will be talking about it in more closely, but especially with respect to prescription drug use, when do we consider excess use as disordered use? Now, there might be some challenges to that, because tolerance and withdrawal are physiologically expected when persons are using benzodiazepines or opioids. And this distinction between hedonism, that the person is feeling good, feeling a high, versus just having the problems eliminated or reduced. Now, where is the line to be drawn, and what happens when the person has both of these effects? A little bit pleasure and a lot of distress distress being alleviated. So when do we start calling that the person has disordered substance use? So description of the adverse health consequence and proving the contribution of substance use to the medical problems that are happening also becomes a little bit of a challenge. For example, if there is a fall, now the fall is due to frailty, sarcopenia, or sensory abnormalities, or inability of the gait difficulties in gait or as a consequence of substance use. So what contribution of substance use would be there to that fall would be a question, and because this question comes up when we want to say that this use of substance is being problematic. So those are certain of the issues. So let me wind up by we had an editorial by Dr. Subhash and myself when we were talking about substance use in the elderly, and we were reflecting that often we conceptualize substance use as a young population issue. Yes, there is maturing out, yes, the prevalences might be different, but nonetheless, because of that, we are often ignoring. Probably we have inadequate training as well, and this leads to hesitation in asking, especially in a non-addiction setting, about different substance of use. And hence there is probably under recognition of the problem, and then there is a denial of the issue, and there may be under reporting. And I'm sure anecdotally you would have heard that a person, elderly person coming up for an elective surgery, the family members indirectly asking whether we should give this, he was been taking opium for a very long period of time, shall we give this opium to this person or not, in hushed voices to the clinician. And sometimes when this discussion does not occur, the person after that elective surgery starts to experience a lot of withdrawal, and he's very distressed, and people do not know why there is so much of pain. So this reflects that we are not asking probably these questions, and we are hesitant to ask these questions, and that's fair enough, but we need to make efforts to make ourselves more aware and cognizant of this problem. So are we seeing the tip of the iceberg? And sometimes it's okay to see the tip of the iceberg, but sometimes it's not. So to conclude, substance use and substance use disorders is not rare in the elderly. Benzodiazepine and prescription opioids can be concern in many of the individuals, and cognizance and training for us as psychiatrists is important, and then that has translational value when we deal with other clinicians from different specialities who may be encountering people with substance use disorders. So with that, I'd like to thank you, and in case someone is interested, do watch Requiem for a Dream. It's a painful movie, but nonetheless it also shows not only substance use in the younger population, but a different flair of substance use in the elderly. Thank you, sir.
So I think we'll take questions together at the end. So Anirudh can start his.
Hello.